So today topic is hematological management, and the speaker we have here is Dr. Varun Arora, who is a consultant at BLK Max Hospital, Delhi. Thank you, sir, for being with us.
Good evening, everyone. So I'll be discussing about hematological management, the questions which are usually asked in part 1 EDIC, both type A and type K questions. So I would request you that you can ask the questions later after this session or in the chat box. I will try to answer all your questions. So let's start. This hematological management part is more theoretical. You have to mug up certain numbers. You have to remember certain terminologies. Uh, I mean, more of theoretical part rather than practical. So let's start with blood transfusion. So in most critically ill patients, the transfusion trigger is 7 grams per deciliter, HB of 7 grams per deciliter. Below 7, you have to transfuse. Above 7, you are not supposed to transfuse. This is based on the trick and twist trials, the very famous trials, transfusion related in septic shock and in critical care. But in certain subset of patients, like the patients who are having coronary artery disease and acute coronary syndromes, you have to maintain a hemoglobin of 10 grams per deciliter. So below 10, you have to transfuse them slowly under Lasix cover. It has been shown that maintaining a transfusion trigger of 10 grams has got increased survival. So they specifically asked that is there any mortality benefit? So yes, the chances of survival increases if you maintain the hemoglobin target of 10. So each unit of PRBC, that is packed RBC, has got 300 to 400 ml of volume. You have to remember this. And one unit increases hemoglobin by 1 gram per deciliter and hematocrit by 3%. So 1:3 ratio in adult patient without any ongoing blood loss or any destruction. So if you transfuse one PRBC, your hemoglobin will roughly increase by 1. So if you transfuse 2, your hemoglobin will increase by 2 grams per deciliter. So they usually ask in specifically in type K questions. And in emergency situations, you can give O negative RBCs because O negative RBCs don't have any A, B, or Rh positive antigen. So you can safely transfuse this O negative RBCs in emergency situations. So what are the types of RBC products? Usually these days we don't give whole blood. We usually make the components of whole blood and transfuse. So whole blood has got all the components and only indication as of now, it is autologous donation prior to surgery, especially in certain rare types of blood group like Bombay blood group where blood is not easily available. So you can collect the blood from the patient and same patient and transfuse just before the surgery when you are anticipating blood loss. So it contains all. Can you please keep your this Zoom platforms on silent? Yes, thank you. So whole blood has got all the components. Usually it is not recommended to transfuse whole blood. It is no more recommended. Then there is packed RBCs. Each bag has got a hematocrit of 60% and approximately 200 milligrams of elemental iron. Volume I already told you 300 to 400 ml. So 200 milligrams of elemental iron. This you have to mug up. Then there is gamma irradiated blood, where we do destruction of donor T lymphocytes. It is usually done to prevent the graft versus host disease in immunocompromised and stem cell transplant patients. Then there is CMV antibody negative blood. We transfuse this blood in transplant patients and pregnant patients where the risk of complications is high if the patient gets infected with CMV. Then leukocyte depleted blood, it prevents leukocyte immunization in hematological malignancies. So whenever the patient is having any hematological malignancy, you give patient leukocyte depleted blood to that patient. Then there are washed RBCs. The RBCs are washed with normal saline to remove the donor serum, and it is used in IgA deficient patients and in patients with paroxysmal nocturnal hemoglobinuria. So after blood, we have the next component, platelet-rich plasma or PRPs, we commonly known as. So platelets are prepared by centrifuging the whole blood, which separates the platelet-rich plasma. And there are two, SDP and RDP. RDPs are random donor platelet concentrates and SDPs are single donor platelet concentrates. So random donor platelet concentrates contains about 60 ml of plasma in each bag. And it increases, one bag increases platelet count by 5,000 to 10,000. So sometimes you can get the value that one bag increases the value by 7,000. So it is a right option. So anywhere between 5,000 to 10,000, one RDP increases the platelet count by 5,000 to 10,000. And the survival of these platelets are usually 3 to 5 days at room temperature. And these platelet RDPs are not to be refrigerated, as platelets lose shape and release their granular contents once they are refrigerated. Now, for collecting single donor platelets, we do a procedure known as apheresis and is equivalent to 5 to 6 pool units. So they will increase your platelet count by anywhere between 30,000 to 50,000. And it contains 200 to 400 milliliters of plasma. So what is thrombocytopenia? Normal platelet count anywhere between 1.5 to 4 lakhs. So thrombocytopenia is anywhere less than 1.5 lakhs. So incidence, they can sometimes ask of mild thrombocytopenia is 15%, moderate is 5%, and severe is 1.5 respectively. This data is as per PROTECT trial, which was a large randomized trial of thromboprophylaxis in patients admitted to both medical and surgical ICUs. So in patients with thrombocytopenia, you have higher ICU mortality and longer duration of mechanical ventilation. So that is why it is important to know what is the reason behind thrombocytopenia, and you need to correct the thrombocytopenia. Platelet survival in circulation is approximately 7 to 10 days. We know this thing. 7 days we have read in during our physiology days. And one third of the platelets normally are sequestered in spleen. Absolute platelet count is important, but what is more important is declining trend. Declining trends give you evidence of serious clinical problem. So bleeding occurs when platelet count is less than 50,000 if you are doing any surgical procedure. And spontaneously bleeding, somewhere it is written less than 10,000, somewhere it is written less than 5,000. I have taken this data 5,000 from European journals. So, but you can mark anywhere if it is less than 10,000, there are risk of spontaneous bleeding, especially intracerebral hemorrhage. So guidelines also recommend that if platelet count is less than 10,000, you have to remember this figure, you need to transfuse patient with platelet, even if the patient is not bleeding, because there is risk of spontaneous cerebral hemorrhage. Clinical recognition of cause is vital as therapy depends on the etiology. Etiology of thrombocytopenia is very, very important because in certain conditions, I'll enumerate those conditions, you are not supposed to give platelet transfusions to the patient. This is very important. They will definitely ask you if any question on thrombocytopenia comes. So what are the common causes of thrombocytopenia in ICU? It could be either because of decreased production from bone marrow, increased destruction, or increased sequestration. Normally, I've told you one third of platelets are sequestered in spleen. So if there is increased sequestration, either because of splenomegaly or some spleen or liver disorder, you can have thrombocytopenia. Drug induced, there are certain drugs like heparin, S2 receptor blockers, GP2B3 inhibitors, certain kind of antibiotics and alcohol. All these are causes of thrombocytopenia. Then sepsis induced thrombocytopenia in cases of massive bleeding because of consumptive coagulopathy. And then thrombocytopenia associated with microangiopathic hemolytic anemia. So there are three causes of this: thrombotic, thrombocytopenic purpura, hemolytic uremic syndrome, HUS, and DIC. No, decision to transfuse platelets depend on so many factors. What is the absolute platelet count at that point of time? What is the risk of thrombosis? Is there any risk of hemorrhage, which depends on platelet function and whether the patient is going for any surgical procedure or not, presence of active bleeding, and if the patient is having active bleeding, what is the site and how much is the severity of bleeding, and what is the etiology of thrombocytopenia. So patient with TTP and HUS, platelet transfusion is contraindicated. You are not supposed to give platelets. So for TTP and HUS, the treatment requires plasmapheresis. So platelet transfusion should not be done in cases of thrombocytopenic purpura, hemolytic uremic syndrome, heparin-induced thrombocytopenia, post-transfusion purpura, and catastrophic antiphospholipid syndrome. You need to do other therapies for all these conditions only if your platelet count falls below 10,000. When you are suspecting that patient may develop a spontaneous intracellular hemorrhage, which is life-threatening, only in those conditions you need to give platelet. Otherwise, you are not supposed to transfuse platelets in all these conditions. We have to remember all these conditions. So what are the indications? Less than less than 50,000 when a patient is posted for either major surgery or you are contemplating any invasive procedure. For ocular surgery or neurosurgery, the closed space surgeries, the platelet count should be 1 lakh. Otherwise, in a non-bleeding stable patient less than 10,000 and in bleeding patient less than 20,000, you are supposed to transfuse platelets. Now, there is one novel thrombopoietin agonist, eltrembovec. It is used to treat severe aplastic anemia and ITP. It is should not be used for sepsis-induced thrombocytopenia, which we commonly encounter in our ICU. There are specific indications for this novel thrombopoietin agonist, eltrembovec. Now, heparin-induced thrombocytopenia. There are two types of heparin-induced thrombocytopenia. Type 1 is milder one. Type 2 is more severe one. So type 1, it is non-immune mediated, occurs 1 to 4 days after initiation of therapy, specifically with heparin. Thrombocytopenia is mild. It usually resolves spontaneously and occurs, as I have told you, with high dose intravenous heparin. And usually there are no clinical sequelae. But in type 2, it is immune mediated. It occurs 5 to 14 days after initial therapy. Thrombocytopenia is usually severe, occurs with any dose of heparin by any route, either with IM, IV. It rarely causes bleeding problems. There are more thromboembolic complications, and in this condition, heparin must be discontinued. So what happens when there is a heparin or LMWS exposure? Antigen antibody complex is formed, platelet activation is there, which causes thrombocytopenia, and you have arterial and thrombosis and resulting stroke, MRI, gangrene. There are the clinical symptoms. You have to do clinical scoring and assay testing, and it requires heparin cessation and alternate anticoagulation. So type 2, it is more severe and usually it is asked. So I will repeat again, it is a more serious disorder. Antibodies are formed against the platelet factor 4 complex induced by exposure to both unfractioned heparin and or low molecular weight heparin. The platelet count is usually less than 1 lakh, but there is no evidence of bleeding. What you have got, the complications like thrombosis, erythema and necrosis at heparin injection sites, and systemic symptoms like fever, wheezing, tachycardia from heparin boluses. So heparin should be stopped, and you need to start the patient on direct thrombin inhibitors like lepirudin, which has got renal metabolism, then argatroban, which has got hepatic metabolism, and FDA recommends that in patients undergoing percutaneous coronary interventions, instead of heparin, you can give bilipirudin. In HIT type 2 patients, this synthetic factor 10A inhibitor, fondaparinux, can also be given. And in HIT, as I've already told you, you're not supposed to give platelets. But if there's a life-threatening bleeding, then you are supposed to give platelets, especially when the platelet count reaches below 10,000. Once platelet count reaches above 1 lakh in a patient with HIT, you can start this patient on warfarin if patient requires therapeutic anticoagulation. Now, after HIT, there is another uh, thing from which our ICU patient suffers. It is immune thrombocytopenic purpura. These are due to antibodies directed against the platelet surface glycoproteins. So this binding results in accelerated platelet removal by spleen. Evan syndrome is a terminology where ITP is seen together with autoimmune hemolytic anemia. The diagnosis of ITP is by exclusion. You have to exclude other causes of thrombocytopenia. So the diagnosis is clinical. Treatment consists of corticosteroids, IVIG, anti-RSD antibodies, rituximab, cyclophosphamide, azathioprine, and in some severe cases, you have to do splenectomy also. So you may be asked that, sorry, splenectomy is one of the treatments of ITP. Yes, it is. You are not supposed to do splenectomy in TTP, but in ITP. Then thrombotic thrombocytopenic purpura. It is diagnosed by a pentaid of microangiopathic hemolytic anemia, thrombocytopenia, renal failure, fever, altered mental status, and it is caused by the acquired deficiency of ADAMS 13 gene, which cleaves von Willebrand factor molecules. So with this deficiency, the von Willebrand factors are not cleaved. You have large circulating multiples, which results in platelets to adhere to the endothelium and thus the manifestation of this disease. So this syndrome is commonly precipitated by infections such as E. coli, O15 enteritis, which is very important, HIV, or certain drugs like cyclosporine, tacrolimus, clopidogrel, and estrogen-containing birth control pills. So in this TTP also, platelet transfusion is contraindicated, but in presence of life-threatening bleeding, you need to transfuse platelet. If you give platelets without any life-threatening bleeding, it can precipitate vaso-occlusive crisis of vital organs such as brain and heart. You will have thrombosis everywhere. The patient will get stroke, MI, and the treatment is plasma exchange or IVIG. Now you have seen the diagnostic pentaid of TTP. There is thrombocytopenia. So the picture resembles of DIC. Both TTP and DIC are associated with thrombocytopenia, microangiopathic hemolytic anemia, and schistocytes. But what is the difference? In DIC, you have associated coagulopathy. You will have prolonged PT, prolonged APDT, then low fibrinogen levels and high FDP levels. However, degree of thrombocytopenia will be more severe in TTP, and elevation of LDH is more profound in TTP. Platelets are contraindicated in TTP, but platelets along with your coagulation factors, both of these are symptomatic treatment of DIC because there will be associated coagulopathy, as I've already told you in DIC. So you need to know the difference, what is TTP versus DICP. You will get a one full question describing the clinical picture. So you need to rule out whether the patient has got TTP or DIC. Then sepsis-induced thrombocytopenia. The etiology of sepsis-induced thrombocytopenia is multifactorial. Sepsis can cause marrow suppression, increased platelet destruction. There can be drugs, especially antibiotics, which you are giving, and associated DIC. The treatment is usually supportive with therapy directed to underlying cause and use of blood and blood products. So you need to change your drugs, especially teicoplanin can cause thrombocytopenia. There are certain other drugs. You need to stop those drugs and try to correct sepsis as soon as possible. And once your platelet count reaches below 20,000, if there is bleeding, you transfuse platelets. So now thrombocytopenia platelets is over. Let's move to next blood component, which is fresh frozen plasma. So each bag usually has 200 to 250 ml of volume. There are no leukocytes in FFP, so there's no risk of CMV and GVHD. Should not be used for volume expansion and isolated factor deficiencies. For isolated factor deficiencies, isolated factors are available, but they are expensive. You can use them, but ideally should not be used if the patient is not able to afford all those factor deficiencies. You can give FFP to these patients. The FFP can be stored up to 1 year when stored at minus 25 degrees Celsius. And before use, they should be thawed in blood bank in water at 30 to 37 degrees Celsius. Once thawed, they cannot be stored back. You have to use them within 6 hours of thawing. and dosage is 10 to 15 ml per kg. We usually calculate by 15 ml per kg, and whatever volume comes. So like if patient is of 60 kg, you will require 900, that is 4 bags of FFP. So indications when your INR is more than 1.6. So whenever there is inherited deficiency of single clotting factors with no recombinant factor available, and to prevent active bleeding in patient on anticoagulant therapy before a procedure, your INR is more than 1.5, you give platelets. Then another indication is emergent reversal of warfarin. If there is major or intracranial hemorrhage, or prophylactically if you are contemplating any surgical procedure that cannot be delayed. In acute DIC with active bleeding and correction of underlying condition, you can transfuse FFP. Then another indication is microvascular bleeding during massive transfusion. You usually give 1:1:1 ratio of PRBC, platelet count, and FFP during massive transfusion, and as a replacement fluid for apheresis in thrombotic microangiopathies and in hereditary angioedema. Next component is cryoprecipitate. It is prepared by thawing fresh frozen plasma and collecting the precipitate. It contains very high concentrations of factor 8 and fibrinogen. It also contains von Willebrand factor, fibronectin, and factor 13. So as you can see, there is no factor 9 in cryoprecipitate. This is usually asked. Concentration of fibrinogen is 10 times of FFP. So if there's a deficiency of fibrinogen, especially in cases of DIC, consumptive coagulopathy, you have to transfuse cryoprecipitate. So cryoprecipitate is used in cases of hypofibrinogenemia, which most commonly occurs in setting of massive hemorrhage or consumptive coagulopathy. The dose is usually 10 units per kg. So each unit will raise the fibrinogen levels by 5 to 10 milligrams per deciliter, and we have to maintain a goal of fibrinogen levels of at least 100 milligrams per deciliter. So usual dose is usually 10 units of pooled cryoprecipitate. In adults, indications, hemorrhage after cardiac surgery or any major surgery, massive hemorrhage or transfusion, and surgical bleeding. Now, next is recombinant factor 7A. So when bleeding is not controlled by blood products after adequate resuscitation, you can consider giving patient recombinant factor 7A, but make sure that the cost of recombinant factor 7A is very high. Almost 2 milligrams of recombinant factor cost 1 lakh rupees. So evidence outside hemophilia setting is lacking only in patients of hemophilia, certain patients of hemophilia, which develop inhibitors to the factor 8. So in these patients, this recombinant factor 7 can be given in a dose of 90 to 120 mics per kg every 2 hours. There is no decrease in mortality other than hemophilia setting, and patient can have increased risk of thromboembolism. Now, next is prothrombin complex concentrates. There are 3-factor concentrates and 4-factor concentrates. They are indicated in bleeding due to warfarin, that is reversal of warfarin, but they can be given in other cases of bleeding where volume restriction is required, especially in cases of AKI or CKD. They contain coagulation factors 2, 7, 9, 10. The 7 is variable with protein C, protein S, antithrombin 3, and heparin. 4-factor PCC contain higher amount of factor 7 as compared to 3-factor PCC. The advantages of PCCs are faster normalization of INR, smaller infusion volume, and no need for ABO blood typing. The only disadvantage is that they are very costly. Now, what is massive transfusion? There are 3 definitions: replacement of one entire blood volume within 24 hours, transfusion of more than 10 units of PRBCs in 24 hours, transfusion of more than 4 units of PRBCs in 1 hour, and or replacement of 50% of the total blood volume within 3 hours, that is more than 10 units. So what are the problems in massive transfusion? Patient can have circulatory overload, citrate toxicity, and dilutional coagulopathy. So why citrate toxicity? Because 80 ml of CPDA, which is the anticoagulant, it contains 3 grams of citrate. So this high amount of citrate can cause hypocalcemia, hyperkalemia, hypothermia, and acidosis. Now, what are the hazards of transfusion? So you have to mug this up. There can be acute and delayed. Acute is acute hemolytic reaction, allergic reaction, anaphylactic reaction, coagulation problems with massive transfusion. I have already enumerated citrate, massive fluid overload. Then there can be febrile non-hemolytic reaction, metabolic derangements, septic or bacterial contamination, transfusion associated circulatory overload. I will speak about this. Then Trali or urticaria reaction. Then delayed hazards include delayed hemolytic reaction, iron overload, microchimerism, overtransfusion or undertransfusion, post-transfusion purpura, transfusion associated GVHD, or transfusion related immunomodulation. Some of the things I will discuss later. Then there can be infectious complications. What could be there? Hepatitis B, C, human T lymphotropic virus 1 and 2, HIV, Creutzfeldt-Jakob disease, human herpes virus 8, malaria, pandemic influenza, and there are some case reports of West Nile fever also. So what is TRALI, transfusion related acute lung injury? It mimics your ARDS, and it is due to diffuse neutrophil activation and capillary leak, usually develops between 48 to 96 hours. And there are both immune and non-immune mechanisms which are involved. So manifested by rapid onset dyspnea, hypoxia, fever, bilateral pulmonary infiltrates, you will get your picture like ARDS. You'll get your X-ray and CT like ARDS. Picture resembles ARDS, and there is no volume overload or heart failure. Treatment is usually self-limiting. You have to give lung protective ventilation to this patient. Whatever you do in a case of ARDS, you have to follow that. And few cases become severe enough, you have to start the patient on mechanical ventilation. You have to start the patient on muscle relaxants. You might even need to prone some patients. There are few case reports of Trali going to ECMO also. Then graft versus host disease. The donor lymphocytes which are present in your PRBC, they attack the immunodeficient recipient tissue because they consider it as a foreign antigen, and then these donor lymphocytes proliferate. So what is preventive strategy? That you remove the donor lymphocytes. It can be seen post transfusion up to 100 days. This is very important. The symptoms include rash, diarrhea, hepatitis, pancytopenia. It is usually seen following allogenic bone transplantation, which is the most common reason for GVHD, transplantation of solid organs that are rich in lymphocytes, and transfusion of an irradiated blood. So you need to irradiate your blood. You need to remove the donor lymphocytes before transfusing PRBC. And transfusion-related immunomodulation, TRIM. So it has been implicated in post-op patients, recurrence of cancer, and in non-Hodgkin's lymphoma, but clinically only proven in AML patient receiving chemotherapy. Leukoreduction decreases immunomodulation. So what is done to prevent immunomodulation? It is leukoreduction. So many of our ICU patients are on direct oral anticoagulants, apixaban, dabigatran, rivaroxaban. So what should be done? It is again a separate PowerPoint presentation, separate articles, very elaborative, but I will try to finish off in 1 or 2 slides. So reversal of direct oral anticoagulants is inadequate with both FFP or PCC. But if bleeding is there, try to start the patient on PCC, but your reversal is inadequate. The bleeding should be managed expectantly while the drug is cleared naturally from the body. Dabigatran can be removed by hemodialysis. 19% of your dabigatran is usually removed. Only one direct oral anticoagulant is there, which can be removed by hemodialysis. And now there is a new specific reversal agent, idarucizumab, which, if available, can be used. And there are no specific reversal agents for factor 10A inhibitors. Now, last slide, it is about TAG. It is a point of care testing where you will get rapid results like what is the problem in your both coagulation cascade platelet function. So what is the general principle? A small cuvette is rotated. There are actually basically two type of things, thromboelastography and ROTEM. So in thromboelastography, your pin rotates, and in rotum, your cup rotates. But that is not important. What is the general principle? A small cuvette is rotated to stimulate the sluggish venous flow and stimulate the clot formation. The resistance to rotation due to the mass of the clot is measured and a graph is formed. So what we'll see in the graph, it kinetics of clot formation. So this provides information about the clot formation and breakdown and also reflects problems with coagulation cascade and platelet function. So what we see graphically, there are certain things. First is the R. As you can see in this diagram, the R is the reaction time, which is the latency until clot formation. See what is happening here. We have to first understand what is the physiology behind clot formation. So before a clot is formed, there is some kind of latency where the clotting factors accumulate. They will first accumulate and then they will adhere to they will activate our platelets. They will adhere all the platelets and then this clot is thrombolized. So initial part is clot formation and the later part is thrombolysis. So our reaction time is latency. So if your R is increased, that means there is deficiency of clotting factors. Increased R time, you have to give FFP. Now, once your platelet starts once your clotting factor starts activating, this is the R time. Then the clot formation starts take place, and then we have get this K value. This you can see. This time from the end of R until the clot reaches 20 mm of site. Once the clot formation starts, platelet starts adhering to the clot, and what we get is maximum amplitude. It reflects the total clot strength. And from K to MA, we have got this alpha angle, the angle tangent to the curve at K. This is normally 54 to 80 degrees. You have to remember all these values. If you are practicing your tag in a normal daily routine, you must be knowing this value. If you are not practicing, start practicing it if it is available. Otherwise, you have to remember these values. Then the half part of tag is thrombolysis, LY 30% lysis after 30 minutes. It reflects the fibrinolysis stage of clot development. So what are the advantages of tag? The results are available promptly. K and R within 5 minutes, MA and alpha angle within 50 minutes, and your lysis time within 30 to 45 minutes. Now, what to do? If your R time is increased, that means there is deficiency of clotting factors. So you have to transfuse FFP to this patient. If the alpha angle is decreased, that means the clot has not able to reach its maximum amplitude. There is some kind of deficiency of fibrin and factor 8. So you need to give cryoprecipitate. If the MA is maximum amplitude is decreased, clot is not able to reflect its total clot strength. You need to give platelet to this patient. And if the fibrinolysis is delayed, then you consider tranexamic acid, Trenexa. So normal, you have seen anticoagulant factor deficiency, R time is increased. If there is increased fibrinolysis, then you can see that LY 30 has decreased. Normal is 0.0 to 9%. In hypercoagulable state, when there is deficiency of when hypercoagulable state, sorry, when platelet this clotting factors are more, then your R time is shortened, reaction time is shortened. In early DIC, you can see that R is decreased, K is shortened, alpha angle has increased, and MA has increased because of thrombosis, early thrombosis. But when there is consumptive coagulopathy, late DIC, you can see that R is prolonged, K is prolonged, alpha angle has decreased, and also because of thrombocytopenia, MA has decreased. Okay. So now you can ask me the questions. I'll see the chat box. You can directly ask me or you can post your questions in chat box if you have any query. Remember, you have to mug up certain values and certain terminologies where we have to transfuse platelets, where the platelets are contraindicated. So you have to remember all these things because you will get multiple choice questions or true or false questions. So any doubt, you can ask me.
Aspirants, if you have any question, you may ask now.
Or you can ask me anytime during crash sessions, or you can have my number from Miss Fatma or Miss Hana.
Sure, sure. Now,
Okay, thank
I
you.
believe that no one have question now. If any question arises, I'll let you know. Okay?
Okay, thank you. And my best wishes to all the students for your upcoming EDIC exam.
Thank you, sir.
Thank you.